Yeah. But we also need to see whether it is feasible for the practitioners to actually take this and prove that this is practical. What happens only if we have knowledge? We also need to show that this knowledge is converted into practice, and that is why we are debating. And my counterpart, Dr. Deepak, will be standing against the motion of this statement: should oral health education be an integral part of diabetes patient education or counseling? Now, the fact is, as a periodontist or an oral health practitioner, I would definitely be in favor of it, but it is only my endeavor to prove it to you. First and foremost, let us see whether there is any association. So, as we have seen in the previous presentations, that yes, there is a very high association and there is a high prevalence. If you look at the various components of the oral health diseases, we will see that almost more than 90% of the patients have some or the other kind of oral health if they are diabetic. And if the diabetes is uncontrolled, then this prevalence goes quite high. If you look at halitosis, burning mouth syndrome, oral lichen planus, candidiasis, salivary dysfunctions, periodontitis, these are very high. So what we are talking about is not something which is very flimsy, it is very real. That yes, this exists in patients who are having diabetes. When we want to talk about whether education to the patient should be a part, first and foremost, we have to understand that diabetes is a systemic disease and it is not an exception. So you cannot keep the mouth out of your body. So we have to consider that yes, mouth, the oral cavity is a part of our entire systemic system because because diabetes affects overall all the tissues, and you cannot just separate it out and exclude it and saying that you are not amongst us. We have been listening and this is quite established. A lot of publications has been there and now it is the sixth complication of diabetes worldwide. My previous presentations and have presented that how this has been acknowledged. So if a patient who has diabetes and especially uncontrolled diabetes over a period of time, there will be slow progression of periodontal disease and this is what they will land up into. This we do not know, and sadly, many of the medical practitioners also do not have their good oral hygiene. They definitely tell the counterpart that yes, you control the glucose level. They want the HbA1c level to be good, but probably they look at the foot, they look at the eyes, they look at the kidneys, but they probably are not looking at the mouth. Mouth are the gateway, we smile with it, but if we do not have the teeth, and this is what we have, probably we will be left with no teeth to eat. There is a strong bidirectional relationship. So over a period of time, we have now evidence to show that not only diabetes helps the periodontal disease progression, but also if we keep the periodontal disease at check or have regular, timely oral hygiene performance, then the HbA1 level also decreases. Leading periodontists and leading researchers across the world have shown that yes, we can get down the HbA1c level almost to 2.3 to 0.6 level low, and that is quite significant. And that only by maintaining the oral hygiene itself. Now, when we talk about education to the patient in the diabetic clinics or in the diabetic setup or in the oral health setup, first and foremost, we need to understand whether it is possible. Yes, it is possible because these are very early, visible, patient detectable. Patient, if you ask the patient, they will tell that yes, I have some bad breath. And if you at least look at the mouth with a torch or a pen torch, and now we have mobile phones which all come with a torch, you'll be able to see some telltale signs. We last year we had a symposium at Delhi where we conducted a training session among the medical practitioner, and there was a very high response of the medical practitioners to have an oral health training, and we could show them that just simple telltale signs can be identified. So it is not something that we are asking out of the blue, and if you are asking other questions, we can simply look into the mouth and find these warning signs. It is cost effective and public health beneficial. Now, if you look at this, that it does not require a lot of resources. It can be delivered by diabetes educators, nurses, physicians who are working with us. And this is the setup that we are working. It prevents the expensive outcomes. What is the expensive outcome? You will be left with no tooth. You will be left with teeth which you can't chew with. A low cost educational intervention preventing high cost complications is exactly what we need and our health system needs to prioritize. And this, we can do it with simple setups like this. We can have digital or simple physical posters or fly cards where, like this, as I have shown, these are just representative photographs, and we can have it in the diabetic clinics, in the hospitals, or in some areas, or we can have flyers which at least will tell the patients that if you are diabetic, then oral health is also a component which needs to be looked at. Now, if you tell a patient that you don't have a good oral hygiene, that patient may be or may not be very interested. But if the patient has diabetes, that patient will be much more serious. There will be improved adherence. If you tell, because they take the glycemic control more seriously than the oral health. And if the medical practitioner is telling that your oral health is also important, this diabetes is also going to kill your teeth, the patient will be more serious. Just like the patient is more serious about the kidneys, the heart, this, when it comes from our counterparts as a supporting hand, then this is going to go along. It shows better attendance, better follow-ups, and better behavioral entry point. Patients are readily available to understand when both of us together are able to address this alarming issue. Only the oral health telling or only the diabetes telling their counterparts doesn't work. We need to supplement and cooperate with each other, and combinedly when we tell the patient, then there is definitely a better adherence in patient engagement. That is what we are looking for. Now it aligns with modern interdisciplinary care models. Now gone are those days where we will think about a patient only about one organ. Here the patients are coming with comorbidities. They are suffering from hypertension, cardiovascular disease, diabetes, there are geriatric problems, they are on multiple medicines, and there is oral health issues. So if we look that in toto, then it definitely encourages one-to-one and collaborative interdisciplinary approach. And this is what we are moving for. We cannot work in silos. We should come together, and all hospitals, even if we do not have that setup, we can have our linkages and networks together where we can refer the patient and then ask the patient to take it forward in a more concerted way. So interdisciplinary care is not something which is optional now, it is a standard of care. Equity and access. Now, may not be the oral health can be reached to the last mile, but definitely government has got to that level where there is primary health care, and we are reaching to the last mile to the rural and the urban itself. Now imagine a condition where these doctors are trained and these doctors are also helping in educating the patients for the last mile. Will that information not reach them? And if they say that if you have a comorbidity like diabetes, you also need to look, you need to brush better, you need to have a better oral health, then that is going to have a better impact, and this will reduce the inequity. It also is aligned with the global standards, because we need to also look at that how we are standing globally, and this is what we need to practice. That not only we get these strategies aligned with the overall world view, but also we help in healthy aging. There is overall reduction and there is holistic care. So concluding remarks would be the oral health education in diabetes counseling is not an add-on. It is probably a missing pillar. The evidence is strong, the cost is low, the benefits are multidimensional, and the policy justification is compelling. If you truly aim for comprehensive diabetes care, oral health education must be integral but not optional. And my final line would be, when evidence is strong, the intervention is simple, silence is not neutral, it is neglect. I rest my case here. Thank you very much.
Thank you, Anurag sir.